Morning, everybody. Thank you. So, before we introduce the grand round speaker, all right, Angel, we'll get your attention a little bit. Thank you. Thank you. So, yeah, well, great. That works. That works. Awesome. Thank you. Uh, great. Hey, so for the department, we're gonna have resident interview tomorrow and Friday. Yay! Pretty exciting. 60 outstanding applicants over there. We're gonna do it Zoom this year. We did send an email out to the faculty. I do want you to sign on at a particular time. I'll give you the time later on today, just on Zoom. Just gotta show your face on Zoom, and I think the service chief's gonna say a few words about welcoming the applicants. We used to do it all in the HPC back in the days, right? But it was pretty impressive. We're gonna try to do it in Zoom. Live up to technology, right? Abiana, change a little bit over there. So, and also it's Dr. O'Donnell. He's not on, but if you do see him when we send him a note to him, it's Rich O'Donnell's last day at UCSF. Most of you have been trained by Rich. I personally have kind of benefited a lot, being a faculty with him. Obviously, send him a kind of a grateful note and kind of wish him the best. So thank you. So,
well, thanks everybody, and hello to everybody on Zoom. And it is my sheer pleasure and delight to introduce our grand round speaker for spine this year. And John Rhee has been pretty much a academic powerhouse at Emory University, and he's been professor there for 20 plus years, and he hasn't moved. So that must have been, it's a great place to work. Yes, that's like a lifer. But he was also my co-resident, and we were the first 2 years of our lab residency for the 6-year program. And we are kind of like UCSFers as well. So he did his undergrad over at Stanford University, med school at UCSF, residency at UCSF, and did a fellowship at WashU St. Louis with the 2 great powerhouses there in deformity and cervical spine, Larry Lenke and Dan Rue. He subsequently took a job with Scott Bowden over in Atlanta Spine Center at Emory, and has been there ever since with our other colleague and co-resident, Tim Yoon. John, over his career, has achieved quite a bit of things that I am very envious of, and he's authored and co-authored over 80 peer-reviewed papers, and a similar number, almost 80 book chapters, and has been editor of several major textbooks in spinal surgery. And he's also has been an avid educator for the Cervical Spine Research Society, has chaired multiple committees for the Traveling Fellowship, the CME, and has served as the past president, is currently the past president of the Cervical Spine Research Society, a huge achievement for one of the best societies in spine surgery. So without further ado, welcome, John. I'm thrilled that you're here to give us a talk on what really needs to be done and what's too much.
Thanks so much, Bobby. Thank you. So thanks for those very kind words. And before I start, I also want to thank all of you here in the Department of Orthopedic Surgery at UCSF, along with Bobby and Drew, for this very kind invitation. As Bobby alluded to, I have deep roots here at UCSF. I went to med school here for 4 years. I did 6 years of orthopedic training, including the lab year that Bobby mentioned. And so it's really humbling for me to come back 24 years after graduation and be in this position now. So thank you again. This is truly a great honor for me. Last night, I had an opportunity to go out to dinner. The orthopedic spine team and our neurosurgical colleagues took me out to this great restaurant, and wonderful Italian food, fellowship, and fun. And I want to thank all of you who came last night, because you really made me feel welcome. And UCSF is always going to be home for me to a certain extent. But last night, I felt like I came home. And finally, before I start, I want to give a little shout out to Bobby Tay. he and I have some very deep roots together as well. So we were residents together. And as you can see, he was one of my groomsmen at my wedding. And Bobby alluded to the fact that we were both in the lab. And I had the good fortune of following Bobby because during that year, Bobby did a tremendous amount of really innovative work. He developed this mouse model of spine fusion so that you could use transgenic mice and use a variety of different molecular biology tools, and also came up with a mouse model of the Ilizarov technique. So when I came into the lab, I got to kind of glom on to what he had already started, and I got to hit the ground running rather than starting from scratch. And it was due to his graciousness that allowed me to do that. And so I always think of Bobby in that way. He's obviously very accomplished and innovative and smart, but at the same time, he's like the ultimate team player. And so, Bobby, thank you for being a spine surgeon that I can admire, an educator, a leader, and probably most of all, a great and dear friend over these years. So thanks for all that. So the title of my talk is the following. A lot of radiculopathy and myelopathy patients have a cervical malalignment, and I put that in quotes, and you'll see why later, based on X-ray measurements. But who truly needs a major deformity correction? And if so, how do you go about doing it? Now, this is a very common scenario that we encounter in clinical practice, where patients come in primarily with neurologic symptoms, but as you work them up, you realize that there's an underlying structural malalignment as well. And on the one hand, there are very powerful techniques for correcting deformity with surgery. But on the other hand, we also recognize that if we're not careful about who we apply those techniques to and do it indiscriminately, I think we expose patients to a lot of risk, morbidity, and certainly the downsides associated with long cervical fusions. So that's why this talk is really going to first focus on who. I think that's probably the more important question. And then after that, we'll address how to actually get the alignment corrected if you decide that the patient does indeed need a correction. I do have some disclosures. I receive royalties and do some speaking and consulting for a variety of different implant companies. I don't think it's going to impact what I talk about today, but I'll let you be the judge of that. Now, I realize that we're not all spine surgeons in this room here, and so I want to do a little bit of housekeeping before we get started and go over some of the basics of cervical sagittal alignment terminology. And I will assure you that if you understand these terms, then hopefully the rest of the talk will make sense. And maybe if you're not a spine surgeon, there can still be some general orthopedic principles that can apply to your subspecialty as well that you might want to consider. But in the radiologic evaluation of cervical sagittal alignment, there's basically two parameters that you really need to focus on, just to keep things simple. One is the Cobb angle, meaning is the spine lordotic or kyphotic? And that's important because lordosis is generally preferable. And that's for two reasons. First of all, the spinal cord's not going to be draped over a kyphotic deformity. And secondly, because when you do a decompression in a lordotic spine, you've got options. You can do it anteriorly, you can do it posteriorly. If you go posteriorly, you can actually achieve an indirect decompression because the lordosis will allow the spinal cord to drift away from whatever's compressing it anteriorly. On the flip side, kyphosis is generally not preferable, and for the exact opposite reasons. First of all, the cord may be draped over the kyphotic deformity, leading to myelopathy. And in order to achieve decompression now, you basically have to go anteriorly, or you can do some sort of lordotic realignment to then allow the spinal cord to drift away from whatever kyphosis was there initially. The other parameter to keep in mind is the sagittal balance. And sagittal balance conceptually is just a measure of where the head sits with respect to the cervical spine. And the way that we quantify it is by measuring what's called the CSVA, or the cervical sagittal vertical axis. And we do that by dropping a plumb line from C2, which approximates the center of gravity of the head, and then measuring the perpendicular distance from C7. So here's why that's important. If you have a low CSVA, That's generally, again, a preferable situation. And the reason being is that the head is centered over the cervical spine, meaning that the weight-bearing axis of the head actually helps to maintain your sagittal alignment. This has been called a energy efficient or economical position. So think by analogy about a bowling ball that's been perfectly positioned on top of a modified bowling pin. So the weight of the center of gravity of that ball actually helps to maintain that alignment. And in the cervical spine, that means that the extensor muscles don't have to do a lot of work in order to keep the position of the head with respect to the neck. On the other hand, if you have a highly positive CSVA, that's not preferable, because now the weight-bearing axis of the head actually exerts a kyphogenic moment on the cervical spine. So going back to that analogy, it's like the bowling pin's been placed at an angle. Gravity no longer works in your favor, which means in the cervical spine, the extensor muscles have to do a lot of work to try to maintain the position of the head with respect to the neck. So that's it. Those are the only two things that you really need to understand to be able to follow the rest of the talk. Now, remember initially I said that patients who present primarily with myelopathy and radiculopathy come wrapped in what I would call different alignment packages. And what I mean by that is, on the one hand, you can have patients like this with favorable alignment. So he's lordotic, he has a favorable low cervical SVA and sagittal balance. And in situations like this, you've got options. You can go anteriorly and do a 2-level ACDF, which is what I did on this patient. But you could also, depending on the circumstances, go posteriorly with a laminectomy infusion or perhaps even a laminoplasty. So the benefit of favorable alignment is that all you have to do then is to focus on not making it worse, right? You don't necessarily have to make it better, and you can focus and tailor your treatment to the neurologic decompression and stabilization. On the other hand, we also see patients like this, though, with horrible sagittal plane alignment. This type of person comes in with severe neck pain. They have trouble with horizontal gaze. They can't look forward at the world as they live their daily lives. They have swallowing issues. If you've never done this, put your head down and try to swallow. You notice it's kind of hard to do, right? So imagine living like that and trying to eat a bolus of food with your head down like that. It's difficult. They can have hygiene issues because you don't have access to that part of the neck to clean it, and comes in with this severe chin-on-chest deformity. So obviously, this is a horrific, difficult problem, but in a way, decision-making for something like this is actually fairly straightforward, because if you're going to treat myelopathy in a patient like this, then clearly you have to address the alignment. That's part of the problem. But what about these patients that fall in between those two extremes? There's some degree of kyphosis and/or positive sagittal balance, but they don't rise to the level of the guy that I showed you before, where you could look at him across the room and say, I know what his problem is, right? When do you need to really do more to correct the overall sagittal alignment in people like this, versus when can you just treat the neurologic problem at hand, meaning the myelopathy or the radiculopathy? So it's a very important question, and it's complicated. There are some benefits of doing an overall deformity correction. You're going to get a global alignment that's better. You're going to treat all potential symptom generators. And some of the recent literature suggests that maybe doing this will get you better patient-reported outcomes. Now, it's interesting because for a number of years, the orthopedic and spine literature suggested a disconnect between radiographic and clinical outcomes. But recently, those have started to merge to some extent. But on the other hand, we can also think of a lot of downsides to doing a major realignment operation. It's invariably going to involve more fusion levels than you would need to do just to treat the neurologic issue. And therefore, it's a bigger surgery with greater morbidity and higher complications. And those complications aren't trivial. This is a study of a cervical deformity database, which showed that the overall perioperative complication rate from treating cervical deformity is upwards of 40%. And that study doesn't even mention some of the longer-term mechanical failures that can occur as a result of the long fusion constructs that are done, like distal junctional kyphosis. So this is a patient who was sent to me after having anterior posterior fusion, presumably for some sort of kyphosis, is what the patient said, and developed this chin-on-chest deformity that then required pedicle subtraction osteotomy in the upper thoracic spine and even further extension of fusion. So this question of who is very complex, and in order to try to answer it, I'm going to start by explaining why I think the cervical spine shouldn't necessarily be treated like the lumbar. Here's what I mean by that. In the lumbar spine, kyphosis and sagittal imbalance are extremely poorly tolerated, and they're almost always symptomatic. Whenever you see somebody like this with very positive sagittal balance and lumbar kyphosis, they will almost always have incapacitating back pain, difficulty standing upright and doing their daily activities. On the other hand, though, in the cervical spine, kyphosis and sagittal imbalance are not necessarily either pathologic or even symptomatic. And as a matter of fact, it's relatively common to see people like this with 40 degrees of kyphosis, significantly positive cervical SVA, who come in with only myelopathy or radiculopathy and have no neck pain, no symptoms of spinal deformity. And in this meta-analysis of 21 studies and over 15,000 asymptomatic, quote-unquote, normal adults, the authors found that only 68% of normal people actually display lordosis, on average of about 13 degrees. So think about this. If 1/3 of normal asymptomatic people are not lordotic, then clearly our job as spine surgeons is not necessarily to try to make everybody lordotic, right? Well, what about that other parameter I asked you to keep in mind, cervical sagittal balance? If you look at CSVA studies in asymptomatic people, normal values range anywhere from about 0.5 to 2.8 centimeters. So you might then ask, well, should there be a target or goal CSVA for all cervical patients? What about 4 centimeters? That's a number that often comes up in the context of this discussion. And one of the major reasons for that number being so prevalent in discussion about this topic is due to this paper that was published in 2012 by Tang. And this is a very important paper, but I will say that I think that this paper has been misquoted, not by the authors, but by others who might not necessarily understand how some of the results of this study apply and don't apply. Let me explain that to you a little bit better. They took 113 postoperative patients who had undergone a posterior cervical fusion of about 6 levels on average and followed them for 6 months post-op. And what they found is that the CSVA correlated positively with the neck disability index, meaning that the worse the sagittal balance, the worse the clinical outcomes. And what they also found is that on regression analysis, a CSVA of more than 4 centimeters had the most significant correlation with the neck disability outcome. So that right there is where that 4 centimeter number came up. And again, this is a very important study. I'm not trying to minimize or criticize it, but I think we do need to be careful not to extrapolate these results beyond the study population that was in this study, which is patients who had undergone a multi-level, 6-level posterior cervical fusion. So I think on the basis of this study, it's reasonable to conclude that a CSVA of less than 4 is associated with better outcomes in patients undergoing multi-level posterior fusion. So in other words, if you're trying to correct the deformity, make sure you correct it properly and get the balance right, and the patients will do better. But in no way does that imply that all cervical myelopathy and radiculopathy patients have to have a CSVA less than 4 in order to have a good outcome. So let me try to explain that a little bit further, because I think this is really important. If you follow that train of thought to its logical conclusion, and insist that every patient has to have a CSVA less than 4, what do you do about the typical elderly patient with myelopathy who has a positive cervical sagittal balance, but it's not due to an alignment problem in the cervical spine, it's due to thoracolumbar alignment issues? Maybe they have compression fractures or disc degeneration in the lumbar spine. Well, then you would have to say that treating the myelopathy would have to include a thoracolumbar fusion with osteotomies to try to get that alignment right, because that's the driver of the cervical SVA being positive. So now instead of treating this elderly patient with maybe a 1 or 2 level ACDF, we're talking about a C2 to pelvis fusion. Okay? Obviously, that does not make sense. And in fact, some recent literature bears that out. In this study, patients with cervical deformity undergoing ACDF experienced as good, if not better, patient-reported outcomes compared to those without deformity. So this study came out of Jefferson, and let's look at it a little bit more carefully. They took their 1 to 3 level ACDFs. So these are patients clearly that are not undergoing a major deformity correction, probably just treating the neurologic symptoms. And they separated these patients according to their pre-op CSVA. In one group, the deformity group, so to speak, the CSVA was greater than that magic number of 4, and it went from 4.9 centimeters pre-op to 4.4 post-op. So again, they are not trying to correct this CSVA, and yet the NDI scores improved tremendously by 19 points. In the other group, the so-called normal group with a CSVA of less than 4, that value went from 2.4 to 2.5 centimeters. So again, not a major difference. And the NDI scores improved by 11 points, but not as much as in the deformity group. So you can see here that patients with a residual so-called deformity actually improved more in terms of their outcomes, even though that deformity remained uncorrected. So the bottom line is that not every cervical patient needs to have a CSVA less than 4 in order to have a good clinical outcome. In this study, I think the disability was not driven by alignment per se, but by the underlying neurologic condition. And many of those types of patients will do well simply by treating the myelopathy and the radiculopathy. So given all the complexities and nuances of all that, are there some general principles to consider when treating radiculopathy and myelopathy patients who come in with varying amounts of sagittal malalignment? I'll make a little plug for the CSRS. There's something called the Video Archive, and more recently that has been transitioned to a YouTube channel that Bobby Tay and Brian Sue have been instrumental in setting up. And this talk and many others are on that channel if you want to look in more detail. But I think of 4 general principles when treating these patients with imperfect alignment. First, you got to determine if there is in fact a true symptomatic deformity requiring correction, or if we're just talking about what I would call a radiographic malalignment. Now that might seem straightforward, but you ask a little further and say, well, how do I actually define that true deformity that requires correction? I don't know if I have an exact answer for you, but I'm going to paraphrase a famous quote by Supreme Court Justice Potter Stewart. So he was asked to define pornography. And what he said was, I can't really define it in words with verbal criteria, but I know it when I see it. And in the same way, I think establishing absolute numerical radiologic criteria for deformity correction is a problematic slippery slope. So think about a patient like this with 2-level myelopathy. They have some slight increased kyphosis, 11 degrees. CSVA is slightly positive, above a threshold of 4.1 centimeters. So on the basis of those measurements, that patient would qualify for a major deformity correction as based on multiple studies in the literature, because they break that threshold. But really in a patient like this, would I want to subject them to a major deformity correction just because these numbers cross the threshold? No, I certainly wouldn't. And I think this is where x-rays alone don't tell the whole story. So the history and physical, like anything else in medicine, are really critical. And if you're going to recommend a major deformity correction, I think the patient has to have symptoms of cervical deformity, muscular fatigue. They have trouble holding their head up. They have a lot of neck pain from doing that. They have trouble with horizontal gaze. We talked about swallowing, hygiene issues, et cetera, in the end stages. And they should have on exam an externally visible deformity. In other words, if you carefully examine the patient and can't even tell that there's a deformity, it's probably not worth treating, okay? So here's an example of a case like that. Patient came in with isolated C7 radiculopathy. You look at her, she looks totally normal. There's no visible deformity at all, and you can tell that by looking at her soft tissue shadows there. But on x-ray, she has 27 degrees of kyphosis, fairly significant. But I treated her with a single level ACDF and all the symptoms completely went away. There was no way that I could justify fusing more levels on a patient like this just because the numbers didn't quite add up. So in my opinion, the X-ray measurements and criteria can tip the scales in favor of doing a major deformity correction, but X-rays alone shouldn't be the sole factor in decision-making. And we recently published a study on this, looking at when are sagittal realignment procedures necessary in these patients presenting primarily with radiculopathy and myelopathy. And this was a survey study of international cervical spine experts, and we asked them 3 questions. The first being, which radiologic criteria by itself establishes the diagnosis of cervical deformity? And we asked about ones that are commonly reported in the literature: CSVA of greater than 4, kyphosis more than 10 degrees, chin-brow vertical angle of 25 degrees. And in our expert panel, none of these variables in and of themselves reached 50% consensus. The chin-brow angle did come close, though. It was 49%, but I think it's because it's more of a functional measure. It's not purely a radiographic measure. You measure the angle that the face makes with a plumb line to the vertical, and you can see that this will tell you information about the patient's line of sight. The second question that we asked is, in a patient with radiculopathy, when would you do a more extensive deformity correction than needed to just treat the radiculopathy to normalize some of those parameters, the CSVA, the kyphosis, et cetera? If there was only radiculopathy, 10% of our respondents said they would do more surgery. But if you then added symptoms of deformity, difficulty holding their head upright, et cetera, that number then went up to 85%. And finally, we asked a similar question in the myelopathy patient. When would you do more surgery to correct alignment beyond what's necessary to just treat the myelopathy? Well, if there was symptomatic myelopathy, only about 51% said they would do more. And if you think about it, that makes sense in certain situations because, again, kyphosis can cause cord compression. But like the other case, if you added neck pain, difficulty holding head upright, and other symptoms of myelopathy, that number then went up to 93%. So what we concluded is that cervical deformity should not be defined on the basis of any single individual radiologic criteria alone, but that deformity symptoms need to be factored when deciding on the need for major realignment surgery. So the second general principle of treating these patients with imperfect alignment is to always do an operation that will, at a minimum, maintain alignment and not make it any worse. And in that regard, we avoid multi-level laminectomy. We talked about this in the case discussion previously because it can lead to this sort of severe post-laminectomy kyphosis. But the truth of the matter is that some loss of lordosis and sagittal plane worsening can occur even after alignment-preserving operations like laminoplasty. So in order to maintain and not worsen alignment in patients like this, I think you have to pick them very carefully. So for example, this patient only has 5 degrees of kyphosis, which is certainly within the range that would be acceptable for a laminoplasty based on the literature. But if you look at their CSVA, it's borderline positive at 3.6. So in my mind, this combination of some kyphosis with some increase in CSVA is a setup for losing more lordosis after laminoplasty, and I would consider probably doing something else. Paradoxically, somebody like this may actually be a good candidate for laminoplasty. They have a horrible looking neck, and they're kyphotic in the upper cervical spine, but he has lordosis where he needs it, which is in the area of cord compression. So somebody like this, we could treat with a focal laminoplasty and improve the neurologic situation and not bother the alignment at all. The third principle is to, whenever possible, improve alignment at the operative levels, as long as doing so doesn't unduly increase either the risk or magnitude of surgery. So for example, little tips, like if you're doing an ACDF in a kyphotic segment, if you place the pins divergently like this, then as you distract, that distraction will get converted into a lordotic moment and help you generate some lordosis. This is an 80-year-old woman with myeloradiculopathy and kyphosis, about 40 degrees of kyphosis from C3 to C6 that we treated with this technique. And you can see you get about 50 degrees of correction overall. It's a very powerful tool. The other strategy to keep in mind is to fill the disc space with as large a graft as possible for better maintenance of deformity correction. So in that regard, my current graft preference is to use these large footprint lordotic cages because I think they better load share and they cause less settling. And we recently published this paper showing that these large footprint titanium cages better preserve the lordotic correction that was achieved at the time of surgery. So if you look at the segmental lordosis at the operative level versus pre-op at each level, with the cages, you got about 6 degrees initially, and by 1 year, the vast majority of it was maintained, 5.8 degrees. In contrast with allograft, we got a similar amount of initial correction, 5.6 degrees, but by 1 year, the construct had settled and about 50% of that initial correction was gone. So here's a clinical example of a patient with modest kyphosis and 3-level myelopathy that I treated with this approach and maintenance of corrective alignment over time. And the final general principle in treating these patients with imperfect alignment is to correct any deformity that's actually causing the cord compression. So this is a 21-year-old college student who was sent to me by an outside surgeon with weakness in the left arm and leg. You can see that she has significant cervical kyphosis as well as a bit of a cervical scoliosis. And on her MRI, the spinal cord is absolutely plastered up against the vertebral bodies as a result of the deformity. And on the axial cuts, you can see that the spinal cord is really taken the shape of a thin, like boomerang. And there's also some dorsal compression from epidural fat. So in addition, making this case even more complex is the fact that she has very small abnormal lateral masses, meaning that fixation power and corrective power may be limited if you rely on lateral mass screws. So then we looked at the pedicles, but they're also very small and abnormal as well, particularly on the left side if you compare it to a more normal pedicle that I've shown here on the right. So in a patient like this, though, the deformity is the problem. The deformity is what's causing the spinal cord compression. So the goal of treatment is to correct that deformity, to treat the myelopathy, and at the same time, in a young person like this, to fuse as few segments as possible for long-term avoidance of disc degeneration and adjacent segment disease. So I did a back-front back on this patient and did a direct decompression by corpectomy as well as indirect decompression by correcting the alignment. Overall about 50 degrees of correction, and the patient did very well. All the symptoms pretty much went away. And here you can see that we use the corrective power of pedicle screws when anatomically feasible in order to fuse a very short number of segments rather than doing a long fusion on this 21-year-old girl. Okay, so that's the who. How about the how? Now that you've decided that the patient does need a deformity correction, how do you do it? Well, there are a number of different surgical algorithms that have been published for deformity correction. But the one that I use, because it's simple and easy to remember, is based on the flexibility of the deformity. And again, I would refer you to the CSRS archive or the YouTube channel because there's a more detailed talk on this subject. But according to this rubric, there's basically 3 types of cervical deformity. The first is flexible, meaning that the cervical spine is passively correctable into a desired position. And if that's the case, then you've got a number of different surgical options. You could go all anterior, for example. So here's a patient with a relatively flexible deformity. He has 3-level myeloradiculopathy from C4 to C7. This is a moderate deformity, but you can see on the extension film that it's essentially passively correctable just by extending the neck. And so in this patient, I did a multi-level ACDF to decompress and realign the spine. Now, sometimes with a flexible curve, you may do an all posterior construct. So this is another patient, different patient with multi-level myelopathy, but now a bit more kyphosis than the patient I just showed you earlier, and myelopathy involving more levels. But again, on extension, it's pretty much correctable into a desirable alignment. And so here we did a C2 to T2 decompression with fusion because of the greater severity of deformity and the fact that there were a longer number of segments that were involved in the kyphosis. Her bone quality wasn't as good as well. And so I didn't trust an all anterior construct. Now, finally, with a flexible deformity, even with a flexible deformity, sometimes you have to go front back. And generally, if that's the case, it's going to be to try to ensure the development of a solid fusion. So this is one of the most interesting cases I've ever treated. It's a 35-year-old woman who had had years of neck pain, but now came in with symptoms of myelopathy. And if you look carefully at the x-ray, you can see that there's spondylolistheses in the upper cervical spine, as well as a generalized kyphosis. But when she extends, it's fully correctable. Look even closer, though, and you can see that there's been a tremendous amount of bone loss in the posterior elements of the cervical spine. Get an MRI, there's no masses, and a CT scan just shows that the bone has vanished or disappeared. It's just gone. So this is a very rare disorder that I was first taught about by JOJ here at UCSF, called Gorham's disappearing or vanishing bone disease, where bone just disappears and goes away. And because of the massive bone loss and the potential that this thing can spread to adjacent segments like a cancer, we needed to ensure that this patient fused. And so I did a front back from occiput to T2 to ensure fusion and protect against local spread. And you can see that we used some ribs to strut that big defect from the occiput down and reconstruct the deficient posterior elements. Now, the second type of deformity is rigid but not fused. So in these patients, you can't passively correct them into a good alignment, but on the flip side, it's not fused. So that means there are open disc spaces that you can use in order to achieve decompression and correction. And typically with these patients, we'll go anteriorly and posteriorly to take advantage of those non-fused discs. And the classic example of the rigid but not fused deformity is the post-laminectomy kyphosis. So this is a 73-year-old woman who had an ACDF as well as a laminectomy about 30 years ago, did reasonably well from that operation, but over time developed this severe post-laminectomy kyphosis with progressively worsening myelopathy. You can see on MRI that her spinal cord is severely compressed and atrophic with myelomalacia. And in fact, this is a rigid deformity. On extension, the deformity really doesn't change much at all, maybe a little decrease in the CSVA, but that's really about it. So in this patient, we went anteriorly to decompress the spinal cord and also to achieve lordotic correction, and then posteriorly to hold the correction in place. And the final type of deformity then is fully ankylosed, meaning that it's solidly fused in kyphosis. And if it's solidly fused, obviously, you're not going to be able to passively correct these sorts of patients. So logically, if it's fused, the only way to get correction is then to do some sort of osteotomy. For example, a PSO, pedicle subtraction osteotomy, or a VCR, vertebral column resection. So for those of you who are not familiar, a PSO, basically you just take the spine apart. You take out the lamina, the facet joints, you take out the pedicles, and then you enter into the vertebral body and take a wedge of bone out of the vertebrae to weaken it, so that when you apply a corrective force then, namely compression, you can achieve lordotic alignment with osteotomy closure. So this is a patient that was sent to me with a chin-on-chest deformity. She had undergone a previous front-back surgery and had leftover OPLL with the cord being draped over it. You can see that unusual-looking OPLL at C3-4. She also had a spondylolisthesis at T1, T2, C1, C2 osteoarthritis, and to top it all off, she's solidly fused in kyphosis from C3 to C6. So in this patient, I did a T1 pedicle subtraction osteotomy, which accomplished a couple things. First of all, it realigned the spine, got her chin off her chest, and improved the alignment parameters. But at the same time, by realigning the spine, we could achieve an indirect decompression away from that OPLL and get the spinal cord decompressed without having to go back in through an operative area that had that severe OPLL. And the final option for the ankylosed spine is to do a back front back operation. Another patient that was sent to me who had undergone an anterior posterior fusion many years ago, the screws loosened apparently, so the surgeon just went in and took the screws out. And that's probably not the best thing to do, right? You got to fix whatever's causing the underlying issue. So predictably, when the screws were taken out, the patient started developing this progressive kyphosis and a chin-on-chest deformity. And if you look at the CT scan, you can see that she is solidly fused from C2 to C7 posteriorly. But anteriorly, although there's a solid fusion at C4-5 and C6-7, there's a non-union at C5-6. So step one in this patient was the first posterior approach. I positioned her prone, tried to maximally correct her, see what we could get. And you can see that there's absolutely no correction at all. The only thing that happens is that she hyperextends through the occipitocervical junction, which is not the way that you want to treat this problem. So we placed our fixation points from C2 to T3 and did a posterior column osteotomy, which is basically a very wide laminectomy with total facetectomies to expose the nerve root from pedicle to pedicle. So that was step one. Step two was then the anterior approach. And to do this, you need to scrutinize the location of the vertebral arteries and know where they are so that you can then protect it and then burr down the fusion mass, remove it with curettes and kerosins to loosen things up. And at this point, once you've done that, because she's loosened up in the back and loosened up in the front, the only thing actually holding the spinal cord or the spine in place is soft tissue. It's a very unstable situation. But if you've positioned the patient appropriately, you can then now start to do some correction. By removing some of the bumps that you put under the head and pushing on the head, you can actually correct the spine now that things have been loosened up. And this is what it looked like after the anterior approach. You can see that there's some folds that appear in the back of the neck, the skin. And we also placed a small single hole plate with short variable screws. I purposely used a small plate with short screws to prevent translation during the final stage of flipping, but still allow for some further correction during that last stage. And the final step then was simply to position her posteriorly, put in the rods, and complete the fusion. And so you can see that with a back-front-back approach, it's a very powerful tool for correcting these sorts of ankylosed deformities. So in conclusion, when patients present to you like this, primarily neurologic symptoms, but have some degree of underlying sagittal malalignment, I think the first thing to do is pause and ask yourself, does this patient really need the entire deformity corrected? Because sagittal alignment is clearly very important, but just like we don't operate on every patient who has asymptomatic spinal cord compression, I don't think we should reflexively recommend major deformity correction purely based on these radiographic measurements. Always think about alignment. And I tell the residents and fellows, think about what your mom told you, right? Always leave something as good as you found it or a little bit better. But in the process of doing that, don't turn every degenerative case into a deformity case, because if you do, you'll be doing way more surgery than the patient needs. And in the process, you're actually going to create some deformities that didn't need to be created in the first place. If you do decide to correct the deformity, though, I find it helpful to categorize it according to its flexibility. And if you're going to go for it, you got to make sure you get the numbers right, get things properly balanced, etc. If you categorize according to flexibility, I think it's easy to remember and it makes sense because the treatment options then follow. There's certainly more complex and comprehensive approaches to this, but this one works, in my opinion, for a variety of different deformities, whether they be small deformities or significant chin-on-chest deformities. So once again, I thank you for your attention. It has been a tremendous honor speaking with you, and thank you once again.
Thank you so much, John, for being here with us and giving us such a great talk that makes sense, right? And as you can imagine, as you can tell, he's such a great educator, and that's how he's risen up the ranks of the major societies that are all about education. So it should be inspiring to all the residents that you can achieve this. Look forward to actually having you back when you're now the president of NAS, well, Arthroplasty Sports. I have to have DEI, right? Include everybody, trauma, the Senate, Congress. So as people are thinking about their questions, the one question I had was, and for people like me who try to do less, when is less? How long does the less last?
Yeah.
Like, we do less. We don't operate on all the levels. We just do what the patient needs at the moment. But like with fractional curves, just treating a fractional curve in lumbar scoliosis, they only last for a short period of time. And then you end up needing the big operation. So, from our group, it's like, why not start with the big operation? Because they're going to eventually need the big operation. What's the timeline?
Yeah. I mean, that's a great question, and I wish I had an answer to that. But the way I think about it is, first of all, cervical and lumbar, I think, is very different in many ways. As I mentioned, cervical is often asymptomatic, whereas lumbar typically is not. But the way that I think about it when I design these operations is to do an operation that takes care of the problem now and doesn't burn bridges for the future, and maybe actually build some bridges so that a future operation is now going to be better than what it could have been if I didn't do what I'm doing now. So in other words, in that regard, a multi-level laminectomy is not the right thing to do because it burns bridges. It treats the problem now. They do fine immediately, but over time they get problems, and it's something that didn't need to be done. So I think in my mind, that's how I think about it, is to figure out that sort of sweet spot, treating the problem, not necessarily doing too much, but making sure that you don't burn bridges for the future.
Hey, John, thanks. Welcome back, first of all. And John was actually chief resident here when I was a fellow. So welcome. And thanks for a really sensible approach to how to deal with deformity in the cervical spine. And I think your survey would have been interested. That was your AO knowledge forum. If you had also done a parallel one with the deformity knowledge forum, and I think we'd see some very different answers. But I think your answers were very sensible. So tell us, how do you bring T1 slope into the consideration of when you can do things in the subaxial cervical spine versus when you've got to do something in more of the thoracic or lumbar spine?
Yeah, so that's a great question as well. And, obviously enough topic for several more grand rounds. But T1 slope, just for those of you who aren't familiar, is the angle that T1 makes with respect to the horizontal. And so the idea is that if somebody is kyphotic in the cervical spine or has a positive cervical sagittal balance, is it due to the fact that there's a structural problem in the cervical spine, or is it because of the thoracolumbar spine being an issue? So as you recall, I showed you that cartoon of that old lady that's kind of bent over like this. She actually has cervical lordosis. The cervical spine alignment is fine, but what's making her have a positive cervical sagittal balance is the thoracolumbar spine. So you do need to really be cognizant of that and to make sure that if it's a deformity in the thoracolumbar spine, that you're treating that appropriately. But again, this talk is more geared towards the patient who doesn't necessarily have a obvious symptomatic deformity, but has clear radiographic malalignment that some people would say qualifies them for the big whack surgery. And I'm not saying that that's necessarily the wrong approach, but I do think it merits some pause and justification on your part before you submit somebody to that kind of surgery. And to get back to Bobby's question of, why not do it all up front? Well, there's an argument to be made for that, but one of the biggest downsides of doing these long fusion constructs, whether it's thoracolumbar, cervical, it doesn't matter, is junctional deformities, right? So the longer you make a fusion, the more likely it is that above it or below it, something bad's going to happen. And in deformity correction, there is nothing worse than a PJK or a DJK, because what happens is, in the area where your metal is, it looks perfect. You've done a great job. But in the area just below or above it, they've totally fallen off, and the overall deformity is usually as bad as it was before or even worse. So I think that's the argument to try to do less rather than more in the appropriate circumstance. Not always, but I think the point is to be a thinking surgeon, right? Think about these things and don't just reflexively do things based on measurements and numbers.
Yeah. Zoom. Okay. So, is this working? Yeah, I think.
Yeah.
I would love to have like hour-long conversation with you in terms of cervical deformity. I have many questions. And Bobby was looking at me when he was saying that our group do more and fix it all. So that's my approach, to be honest with you. I don't leave anything behind. Take care of all of it, and usually you have one shot. But you're right, there are many complications comes with it. And I've seen that you are doing quite a bit 360 approach in subaxial deformity cases. We moved away from that. We did actually like 15, we collected data because the population was small and we couldn't publish it. But our results show that post-op, perioperative complications or morbidity is so high. Some patients do great, but if they don't do well, they're in the ICU for a couple of weeks, intubated. Then we moved away from that, and we usually start doing more distal osteotomies like pedicle subtraction or VCRs. But 360 is very efficient to correct the deformity. What's your approach on that one? And I don't put lateral mass screws anymore, only cervical pedicle screws. I find that it is like our population is age osteoporotic and they don't usually work. They are not reliable. So first, like, did you see the similar results with the post-op complication on 360s? And what do you think about like lateral mass versus pedicle screws?
Yeah, so I appreciate that, Vedant, and clearly respect all the work that you guys do here. And I'm not by any means trying to say that it's wrong in any way. But I think that, one of the downsides to doing deformity correction back, front, back, or anytime you go anteriorly is that there's a certain incidence of swallowing issues, right? Because think about it, people have been contracted in this position for a long time and you suddenly extend them. That can cause dysphagia. So you're right. If you go anteriorly, that can contribute to that. But on the flip side of that is typically, maybe not in your experience, but generally osteotomies are going to be associated with greater blood loss and, probably more morbidity if you look at papers overall. So I think, for me, I tend not to be algorithmic about these sorts of things or formulaic. So I kind of look at it on a case-by-case basis. That last case that I showed, for example, the more I looked at it, the more I realized that it was just a one-level deformity that was driving all of this at that one level. And if I could do an osteotomy there, then I could correct the overall alignment. So I think it really depends on a case-by-case. And then as far as pedicle versus lateral mass screws, yeah, I think, pedicle screws are clearly better, but they have risk associated with them that lateral mass screws typically do not. So, in certain cases, I will use subaxial cervical pedicle screws, but I personally don't do it routinely for every case. But kudos to you for doing that. But
John, we have one question from Shane from Zoom. He asked, what's the rule of thumb for balancing correction and extension medial dysphagia? So how much can you correct them before you worry about the patient developing swallowing problems?
Yeah, so there it goes. We just talked about that. So I don't know that I have a rule of thumb for that, but I always prepare the patients ahead of time that is very likely to happen. And depending on the circumstances, sometimes we'll be very quick to pull the trigger on a peg tube post-op. But it's an issue because the esophagus has been placed in a kind of contracted position and you suddenly expand it. So I always tell the patients to expect some significant swallowing problems post-op. And then if they occur, we deal with it.
Yeah, thank you so much. Quick question. Is there ever a role for preoperative traction?
Absolutely. Yeah, I think so. Especially in what I would call accordion-like deformities where, every level the disc is degenerated and the spine just kind of collapses down like an accordion. I find it helpful to do some preoperative traction because it's sort of like nailing a femur, right? If you get everything lined up first, then putting the guide wire in and everything is straightforward. If you try to put the guide wire in and reduce the fracture at the same time, it's just harder. So I like using traction. for about a day or two, depending on the circumstances.
Perfect. We're at 8:30, and thank you everybody for participating. Thank the residents for presenting the cases and being here this morning. And especially thank John again for coming and honoring us with his presence and his lectures and his wisdom. So thanks.
Thanks again.